Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Coming up on the podcast today, I'm joined by our deputy editor Nick Bostock to talk about some key news stories from the end of December and the start of this year that are linked to three major issues where we're likely to see some key developments in the early part of 2026. We're talking about the 2026-27 GP contract, what the BMA and RCGP have said the contract needs to address, as well as some of our own predictions about what could happen with this. We'll be looking at what comes next with neighbourhoods and how general practice can ensure it's protected against big changes that could be coming down the track. And we'll be talking about the impact the ongoing jobs crisis is having on the profession in England and what the government could do to address this in both the GP contract and the forthcoming workforce plan. Our good news story this week is about the GPs and other general practice staff awarded New Year honours. That's all to come on this episode of Talking General Practice. Managing a practice right now is a balancing act. That's why a team subscription to GP Online is a smart investment. Not only do you get access to GP Online, your team can access MIMS for their prescribing information, MIMS learning to manage their CPD, and GP Business for practice management advice. That means expert advice on red flags, news updates, HR, finance and contracts to keep your practice running smoothly. Support your staff and protect your business. Check out our team subscriptions at GPonline.com. So first up, let's talk about the GP contract for the coming year, so for 2026-27. Nick, we spoke on the podcast before Christmas about the fact that the government has changed the way it's putting together the GP contract this year. And rather than negotiating it with the BMA, they're consulting with the BMA alongside other key stakeholders, including organisations like the RCGP, NHS Confederation, National Association of Primary Care, and the Institute of General Practice Management. Just before Christmas, the BMA met with officials to discuss its response to the consultation. The BMA made clear that they aren't happy with the change in the way the contract is being put together this year, didn't they?
That's right. Normally, the BMA GP committee would meet multiple times with officials from the Department of Health and Social Care and NHS England as part of this process of developing contract changes for the financial year to come. But in the context of the dispute with general practice and the government over changes to online consultation requirements, the government is treating the GP committee not as a negotiating partner, but simply as one of many GP and patient organisations that it's planning to sort of consult with to inform changes to the contract for 26-27. So the BMA GP committee role has been very much downgraded. And the committee said in the run-up to a planned meeting the tail end of last year with the government and NHS officials that it had made clear that it doesn't accept this change. I mean, BMA said it's not acceptable for this new approach to have been imposed unilaterally by the government and that effectively it abandons the way contract development has worked for many years.
At the end of last year, the BMA published some documents explaining what they want from the contract that's coming up this year. And obviously they were talking to the government and NHS officials about what was in those documents. What are they saying needs to happen now?
This is another point that shows how different the approach to developing next year's GP contract is this time around. Normally the BMA would keep this all under wraps, keep its cards quite close to its chest. Normally the BMA would be talking behind closed doors to the government and NHS England about what it wants from the contract, sharing very little publicly. But this time around, having been effectively sidelined in these, negotiations, the development of the contract, the BMA GP committee's published a list of changes it wants from next year's contract. It's quite high level. Much of what's on the list is no real surprise. Much of it echoes what the BMA has already called for publicly over the past year. It's put out various sort of policy documents and so on. And the BMA says global sum funding for general practice, so that's the core funding practices receive through the funding formula, should rise by about £50 per patient next year. So that would take global sum funding per patient from around £123 this year to just over £173 in 2026-27. That might sound wildly optimistic, given the government's insistence that it doesn't have much money to throw around at the moment. But towards the end of last year, GPs in Scotland agreed a deal that will increase funding per patient by about £42. So that's actually at a very similar ballpark to what the BMA in England is calling for. And an uplift to core funding on that scale would cost more than £3 billion a year to implement, but mostly it would just reverse massive erosion of GP funding that we've seen over the past decade and a half. And this year's contract delivered extra funding, and it stopped the rot in terms of that funding erosion that we've seen over the past decade and a bit, but it didn't fully reverse it, or nowhere near. The BMA says that's why this big step up is needed. And it says that the money, could be used to, or explicitly to grow an additional workforce, provide additional hours from the existing workforce. It's making the case that that money would translate into an increase in staffing in general practice. And we've been talking for a long time now about GP unemployment. Practices can't afford to recruit, and that's why we've seen this shortage of jobs and work in general practice, despite the fact that the profession's under massive pressure and has been for some time. Another big part of what the BMA wants from next year's contract, unsurprisingly, is something to resolve the dispute over online consultation system requirements that we've seen over the past few months. The GP committee wants the government to agree to safeguards and introduce those immediately. It wants the government to work with the providers of online consultation tools that are widely used in general practice to put in place ways for practices to sort of raise the alarm when they hit unsustainable levels of pressure, basically allow more flexibility. That's something BMA GP committee has been calling from the start, since the weeks up to October the 1st, when the new requirements came in and triggered the dispute. They want more flexibility, and that probably means the ability to switch off online consultation systems during core hours if practices feel like they've hit the maximum in terms of what they can do workload wise. So coming back to the jobs crisis in general practice, the BMA also wants the additional roles reimbursement scheme, the ARRS, to be scrapped and replaced with a practice-level reimbursement scheme. That's an idea it's been pushing for a long time. It also wants things like golden hellos, the schemes to encourage new partners into general practice. Also, there was another scheme that was to encourage GP registrars into some of the most deprived parts of the country, with additional payments to encourage them to go there, incentive payments. They want those schemes brought back. That's something the government has said it doesn't think is necessary, so I think something they're unlikely to get. The BMA wants a safeguarding directed enhanced service, and that's something, they want a nationally agreed framework, basically. It would do away with really big variation in funding and support for practices in what's an increasingly demanding area of work for general practice. And they want the government to work with the profession to develop a new costed and funded approach to GP premises. So that's another area where there's been a real shortage of investment over the last decade or more. And the BMA wants a guarantee that payments for vaccinations, various reimbursements that practices receive, are uplifted in line with inflation. And that's to prevent what we've seen in recent years, where those payments have just fallen behind, in terms of real terms costs.
Quite a lot of detail there about lots of the things they wanted. But what's interesting is, as you say, that the process of doing that this year has changed. Those things, all of those things that you were talking about there, in previous years, those are things they would have gone into series of meetings about. They would have argued the case for each of those things, and they would have listened to what the government wanted, and there'd be some potential give and take there. Whereas this time they've had one meeting, haven't they? And they've been able to go in there for, I don't know how long it was, an hour or so, whatever, and only really been able to talk about those things at a very high level, rather than having the opportunity to really argue the case for why all these things need to happen. I'm presumably that's why they've put out so much information like this now, so that, it's there for the government and everybody to read, and hopefully people will be making that case.
I think particularly, as you say, though, that there's a real lost opportunity for that sort of horse trading, we'll do this if you give us this, that sort of thing. That sort of opportunity is just not there, because the number of meetings is down to one from multiple.
And it's not really a negotiation, is it, this year? So, that's a big change. I mentioned earlier, one of the other organisations that's been asked to feed into this consultation is the Royal College of GPs. If you haven't already listened to last week's podcast, I would really recommend it. It's an interview with the new chair of the college, Dr. Victoria Georgiou-Brown, and it is really worth a listen. I thought she was really excellent, and she spoke really passionately about the challenges of being a GP, why she wanted to be chair of the college, and how she wants the RCGP to work for general practice in the coming years, through influencing and providing practical support to GPs and their teams. We talked about a lot of issues, one of which was the college's response to this GP contract consultation. Dr. Giorgio Brown said that the college's full response to the consultation was confidential, but she did talk in quite general terms about what the RCGP said. She said the college had been really clear that any expectations on general practice in the new contract must be realistic and take into account the time, workforce and infrastructure that's available. She also said the college had really emphasised the importance of continuity of care and ensuring practices had the flexibility to adapt to the needs of their specific populations rather than being subjected to lots of simplistic top-down targets and initiatives. Funding will probably also have been a big part of their response. She said to me that the key things the college had highlighted was the importance of patient safety and quality of care and the growing gap between patient need and the resources that are currently available. So it suggests that funding obviously probably quite a big part of that. And one of the other things she said was that the college, really does back the plans to move care out of hospital into the community, but that needs to be matched with appropriate resources. So that might well have fed into some of the things they were saying. So that's what Dr. Giorgio Brown said on the podcast, but there are obviously some other things that the college might well have said in that response. I mean, we're going to come on to talk about the jobs crisis later. You've already mentioned it, Nick, but the college has obviously been really vocal about that, and the previous chair, Dr. Camilla Hawthorne, called for ring-fenced funding for practices to recruit GPs in her speech to the college's annual conference in October last year. So that might well be something that the college mentioned in their response to the consultation as well. Of course, the other thing that will feed into future change to the GP contract is the Cahill formula review, which is currently going on. Nick, you wrote about some documents you found on the Department of Health and Social Care website about what the review has been asked to look at, didn't you, just before Christmas? What did they say?
In the run-up to Christmas, the government dumped out a whole load of documents that fed into its thinking on the 10-year health plan. There was some interesting background in there about GP funding, particularly in the context of the ongoing review of the Cahill formula. That's the formula that's used to distribute core funding to general practice in England. Many GPs have wanted that formula changed for a long time. Experts say it's a massive driver of inequality. The RCGP says practices in deprived areas have about 14% more patients per fully qualified GP than practices in wealthy areas and receive 7% less funding on average. And, Cahill is seen as basically the key reason why that inequality exists and persists. So GPs want a change, but with the talks on next year's contract, the BMA has been completely frozen out of talks on reshaping the funding formula. That's a big deal because changing the formula is something the BMA sees as an absolutely central point in agreeing a major overhaul of the GP contract by the end of the current Parliament, which is something the government has agreed to look at. And what these documents show is that there's some pretty radical stuff on the table. A report from a working group that fed into the 10-year health plan shows that changes the government could look at include things like keeping a larger share of GP funding outside the main contract and using it to directly incentivise staff participation and support enhanced services in the most challenged areas. GP leaders tend to argue that more funding should go into core practice funding to give practices the flexibility to employ the staff they need, deliver services to their patient populations. But, this sounds like the government could be thinking about moving the other way. In the context of neighbourhood contracts coming out soon as well, the idea of keeping more money outside the main contract could also reflect a desire to shift GP funding into those neighbourhood deals, which is something we're going to come on to a little bit more later. The document talks about exploring options for outcome-based payment or proxies thereof as well. And it suggests that the government should consider more patient experience influenced payment mechanisms. It also mentions possibly releasing part of GP payments only if a certain proportion of patients confirmed they were satisfied with the waiting time before their appointment. So if practices with high patient satisfaction are paid more, that raises all kinds of concerns about deepening inequality. Particularly, given that at the moment, low satisfaction is often linked to underfunding. Any changes along these lines, you'd have to tread really carefully in implementing those to make sure that it wasn't something that just entrenched differences between practices. So there are some other lines that show just how significant the changes under consideration by the government could be. particularly in the context of wider NHS reform. As part of the Cahill review, it talks about a need to look at how unmet need and health inequality is best addressed through primary care services. So that's a real starting from zero sort of approach by the sounds of it. And then to reflect that evidence in the funding of transitional general practice models versus alternative approaches. So there's also an acknowledgement that changing the funding formula will have a major impact, given it's been in place for 2 decades now. A new formula could create winners and losers, big gains and losses in funding for different practices. So the way around that, these documents say, is either to implement the change slowly, given the sort of time constraints the government might be up against. You might consider that being fairly unlikely, or with a big bang of additional funding. And you might consider that to be unlikely as well, because the government says it hasn't got any. The question is, when we start to see neighbourhood contracts emerge in the near future and the government begins to make clear its plans for next year's contract, or maybe the bigger change by the end of this Parliament, what will those things reveal about the future for existing practices, the funding streams they rely on? I think what's clear from this is that really significant change is on the table, is under consideration, and this is all happening at a time when the government and the BMA aren't on good terms. Or worse than that, they're hardly talking. So there's quite a bit of uncertainty for general practice given all of those factors.
Also, that will potentially play into some of this stuff, the fact that the government, even though this is the first term of the government, is also very much on the back foot politically as well, isn't it? And under pressure from reform, and particularly under pressure in lots of those areas we're talking about where potentially general practice is underfunded because of deprivation and some of those factors you were talking about, which means that the Cahill formula doesn't work so well in those areas. There's a big question mark about politically how that stuff might come into play, depending on how the government wants to spin it, as it were, to tell the story about what it's doing with NHS funding. When you're looking at the contract as a whole, what's going to happen from April, what's your sense on what will be in the contract? How likely do you think it is that the BMA, for example, will get those things that it's asked for?
The BMA has said it's not expecting massive changes for 26-27 to the basic GP contract. So limited change next year seems fairly likely. But as the outcome of the Cahill review comes out, and we see things like the framework contracts for single neighbourhood and multi-neighbourhood contracts in the coming months, perhaps that's when we'll start to get more of a sense of what bigger changes could be on the horizon. And I think in the immediate future, things like the £50 per patient core funding rise the BMA's called for seems hugely unlikely. I would think a big change to ARRS is also fairly unlikely, given how keen the government is talking about the impact it's had on increasing numbers of GP jobs, albeit with some big question marks around the figures that it uses. Funding-wise, the government's talked about a potential 2.5% pay increase for doctors, which is, something that people have said is not enough. We're likely to see something like that initially as the proposal the government puts forward for the GP contract, and, potentially then a further top-up following DDRB advice. I suppose one thing to mention in that context is that the DDR process got underway earlier in this contract cycle than it has in some previous years. So it's possible that the DDRB advice will land with the government before the contract's announced, I think. If that was the case, then we might see at the very least a sort of smaller gap time-wise between the announcement of what the government wants to put into the contract and then the impact of the DDRB top-up.
That certainly was Wes Streeting's aim, wasn't it, to not have this big gap from April and taking months for everybody in the NHS to know what their pay was going to be for that financial year. You mentioned neighbourhoods there. We're going to come on and talk about that and the 10-year plan in a bit more detail in a minute, and those new contracts which we're expecting to be published very soon, like you say. But, I do think it's probably quite likely there will be some changes to the GP contract to accommodate those new contracts, something that will try and push practices towards neighbourhood working, maybe PCNs towards neighbourhood working. I wouldn't be surprised if we saw some changes like that. The other document we've talked about on the podcast before that could influence the GP contract is the medium-term planning framework for the NHS, which sets out the priorities for the next 3 years. There's a really big focus on access in that, so I don't think that's going anywhere. I think it's quite unlikely that the requirements around online access will change, but there might be some tweaks to that. I don't expect there'll be anything too extensive though. The government's been so bullish about getting that across the line, hasn't it? And the language has been so combative around it. I don't think they would want to be seen to be backing down on any of that. But I might be wrong. Now everyone is basically doing it. They may be prepared to introduce a bit more flexibility. The medium-term planning framework was also that document that suggested introducing a new target for 90% of clinically urgent patients to receive a same-day appointment. I think that's very unlikely for this year. The government said it would consult with the profession on whether to introduce that. And it actually might be something they're looking at as part of this consultation that's going on at the minute about the GP contract. But I've not seen many people who think it's a good target to have, so I'd be surprised if it turns up. And then the other thing I think to look out for this year in the contract is advice and guidance. That's a really big part of that medium-term planning framework. And I think the government really wants to see a significant increase in the use of advice and guidance during 2026-27. But whether, there are going to be any further changes to the GP contract to help deliver that, or whether it's something that the government will expect to be organised at a more local level by ICBs remain to be seen. But I think it's pretty certain that advice and guidance DES will continue into the next financial year. The question is whether more money will be put into that pot centrally, or whether ICBs will be expected to fund any extra advice and guidance activity locally by, shifting money from their elective care budgets. And I guess, how much freedom they have to decide whether or not they do that, or whether they're basically going to be told by the government, you will do that and you have to do at least this much on it. Before we move on, just a quick message. We're really keen to find out what you think are the important topics that we should cover on GP Online and on this podcast. If there are any issues that you think we should be looking at in more detail, or anything that's going on in your local area that you would like us to shine a light on, do get in touch. You can email me at emma.bower@haymarket.com. Do also get in touch if you have any suggestions for our good news slot at the end of the podcast, because we're always keen to highlight the amazing work going on in general practice. On that note, our sister site GP Business is also hoping to spread some good ideas and successful ways of working and help GP practices to learn from each other. If you've had some success in your practice, introduced a new way of working, or set up a new service and think others can learn from what you've done, do think about submitting your case study. We've put a link to our submission form in the notes for this episode, or visit gpbusiness.co.uk and there's a link on the homepage. Moving on, we were talking about neighbourhoods a bit there, and as I mentioned, the other thing we're expecting early this year, which could be out very soon in fact, is a model neighbourhood framework from NHS England and the Department of Health, as well as details of the single neighbourhood provider contract and the multi-neighbourhood provider contract, which are apparently due to start from this April. These are all things that will underpin the move to a neighbourhood NHS, which is obviously a key part of the government's 10-year health plan. Nick, you wrote a really interesting story before Christmas about how PCNs have begun working together to make sure they're well placed to succeed in this new NHS. What was that all about?
This was from a conversation I had with Ross Clark, who's a primary care specialist lawyer and a partner at a firm called Hempson's. We know from the 10-year health plan that the government is planning to roll out neighbourhood provider contracts at single and multi-neighbourhood levels. Those were initially touted as alternatives to the existing GP contract, although there seems to be a sense that the government now sees these deals working alongside practice level contracts. But although we haven't seen these new neighbourhood contracts just yet, so we don't know for sure what they'll look like, the sense is that general practice needs to make sure it's ready to try and win them. That's not something individual practices can do. Single neighbourhood contracts are likely to cover roughly PCN-sized populations, 50,000 patients maybe, and multi-neighbourhood contracts could cover hundreds of thousands of patients, so multiple PCN areas. So what Ross Clark talked about was how general practice is trying to prepare for the rollout of these new forms of contract, and also why it's important that GPs are doing that work to prepare. So he said he's currently working with groups of a dozen or more PCNs to form large companies that would be capable of taking on multi-neighbourhood contracts. The aim of doing that is effectively to create GP-led organisations, that are able to take on those deals at that level, so that funding that flows through them can be cascaded then back down to practices rather than potentially lost to general practice if other organisations like NHS trusts, for example, or hospital trusts, come in and win them instead.
We talked about the fact that enhanced service funding could be pushed out of PCNs and practices potentially towards neighbourhoods on the podcast last year. That seems to be a real fear among many GPs and practices, doesn't it? What we're talking about here is probably local enhanced service funding and funding for the network contract directed enhanced service which governs and funds PCNs. This move is very much in response to that, isn't it?
Absolutely. The rollout of neighbourhood contracts comes in a context of massive scaling back of integrated care boards. ICBs have been told to cut their costs by half, which means a massive reduction in staff and capacity. And as part of that, the NHS wants to shift some of the work that they did onto providers. So effectively then to simplify the relationship with providers as well. So we've already seen moves in the past towards commissioning local enhanced services at PCN level rather than at individual practice level. And the scaled back NHS definitely doesn't want ICBs contracting for enhanced services, which are services outside of the core work that practices provide, with GP practices one by one. We reported last year that enhanced services funding could move into neighbourhood contracts. So, that would mean that whoever holds the neighbourhood contract would be responsible for commissioning or delivering those services, that work. Practices are hugely reliant on the funding that comes from delivering enhanced services. And that's why many are now working hard to try and position themselves to win neighbourhood contracts, either at single or multi-neighbourhood level. If general practice-led organisations win those contracts, they can make sure that local GPs in their area don't lose out on big funding streams that are vital for their survival. And, if they don't, big chunks of funding that practices rely on could go elsewhere. That's the risk. In many areas, GPs are already organised at scale through things like federations, which are effectively at-scale providers of services. But some of what we're seeing now, according to Ross Clark, is PCNs coming together to form really large-scale companies across big footprints, not to provide services directly, but actually just to win the contracts and then subcontract them back down to practices. They don't necessarily see these big companies as a provider vehicle. We talked about potential changes to the Cahill formula and wider GP funding earlier. And these sorts of manoeuvres, practices grouping together in different ways, PCNs forming companies, becoming companies themselves, are all part of the profession trying to future-proof itself against changes that could come with neighbourhood plans, but also those other changes that could generate real sort of uncertainty and shifts in funding that the profession receives.
Yeah, I think it's worth mentioning that we're now in the second week of January, so April is rapidly approaching, and GP practices have absolutely no idea how much they're going to be paid from April onwards. They've no idea about what these new neighbourhood contracts are going to look like and how they might impact on the GP contract or PCN funding. As you said, Nick, there's a real prospect that could happen, that some of that money could be kind of shifted towards neighbourhoods to help get them off the ground. They also don't know whether they're going to be expected to change the way that services are delivered or set up new services as part of next year's contracts, like they had to do in October with online consultations. That had a really big impact. What other business has to manage in a situation like that? How can GP practices be expected to plan for the future and plan to ensure they're financially secure and resilient when they don't have any of this information, and everything could literally change from the 1st of April? They don't even know how much of their core funding will increase by from April. It's really, quite a ridiculous situation. I don't think any other business has to work with that level of uncertainty. I mean, I've talked to accountants and GP partners over the years, and they all say that this is a real problem every year because of the way the GP contract works. But I think particularly this year, with all this uncertainty about what these neighbourhood contracts would mean, I think it's particularly causing quite a lot of anxiety about where everything's heading. As I said, April will come around really quickly. I mean, surely we must be expecting details of these new contracts soon, shouldn't we? I mean, especially if the government is really keen to get people to sign up to them from April. But obviously, details of the GP contract could come out much later after that.
We've been told that neighbourhood contracts or some sort of framework version of them could be published this month, anytime now, really. So yes, we'll be watching out for those, reporting what they mean for GPs as soon as we can. But these next few months up to April will be really key for general practice. like you said, this time of year is always key for practices because it's a time of uncertainty as, GPs wait to find out about funding for the year ahead. But this year we have the added complexity of neighbourhood deals and the sense that what those look like could be at least as important this year as what's in the main GP contract itself. One of the key stories we've been covering over the past couple of years is the GP jobs crisis, Emma, and our senior reporter Kimberly wrote a really interesting news story about this just before Christmas, didn't she?
Yeah, so Kimberly's not here today, so I'll talk through this one on her behalf. As you say, we've been writing about the GP jobs crisis for ages, since the end of 2023, so it's been going on for a really long time now, hasn't it? I mean, obviously, the government's immediate solution to this has been something we've been talking about today, is it expanding the ARRS, Additional Roles Reimbursement Scheme, to include GP jobs. But as, we've discovered and we've talked about on the podcast before, this isn't necessarily working. Before Christmas, Kimberly spoke to 3 GP registrars from Cheshire who have all passed their GP exams and could effectively, qualify as GPs, but they've chosen to remain as registrars until May, which was their original qualification date, because as they described it, the GP job market is so bleak. So all 3 of them ideally want to remain in Cheshire, although all of them said that they would be prepared to move further away for permanent jobs, but not for the sort of short-term contracts that are often the jobs that are available under the ARRS. They're all really concerned that if they want to get a good permanent job, they're going to have to move abroad to do that. One of the GPs Kimberly spoke to actually said that she wouldn't have chosen general practice as a specialty if she'd realised it was going to be like this at this point in her career. And obviously that's a real cause for concern, isn't it? Because it means potentially GPs in medical school at the minute or in their F1 or F2 years, maybe looking at what's going on in general practice now and choosing something different because of some of these problems that they can see people slightly further along their career having. The GPs told Kimberly that the jobs that are available are often very limited in terms of the hours of work. They're often short-term 6-month or 12-month contracts under the ARRS. And that's the problem with those ARRS jobs. They're often limited contracts, in part because of all those things we were talking about earlier in terms of funding and whether there's any security about the funding for those roles is going to carry on year after year. PCNs are obviously worried about that, and so many of those roles are obviously only being offered on fixed-term contracts. And unsurprisingly, GPs are reluctant to up sticks and move to a new area for a fixed-term contract.
Yeah, we've also talked in the past about problems with those ARS contracts being spread across multiple practices and that kind of thing. So without GP registrars being sort of rooted in an individual practice with the kind of support and sense of being really part of an individual practice that comes with that. So part of what we're doing on the podcast today is looking at some key developments we're expecting to happen on these stories in early 2026. And we're talking about this because we're expecting a new workforce plan this year as well, aren't we?
Yeah, so the previous 10-year workforce plan, or the current 10-year workforce plan, I suppose, was published under the last Conservative government in 2023. So as everyone knows, this current government, this Labour government, published its 10-year plan for the NHS as a whole last summer. And in that, it said it would develop a new workforce plan for the health service. So we were expecting to see that at the end of 2025. So it's quite delayed. It now looks as though we won't see it until spring at the earliest, possibly early summer. So what do we know about this workforce plan? I mean, basically, the government said it's looking to develop a plan that supports the overall 10-year plan strategy. So what that's likely to mean is a focus on making sure staff have the skills to work in a neighbourhood NHS, making sure we have the actual staff to run a neighbourhood NHS, and that those staff understand how to make use of new technologies to maximise productivity. What we do know is that this new plan will set out a smaller growth in the NHS workforce over the next 10 years compared with the existing plan. It said that in the overall 10-year health plan. Sorry, lots of 10 years here, isn't it? It's a bit confusing. But that's what it said about the workforce plan in the overall 10-year health plan. And that's because the government thinks there are significant gains to be made with new technology, which means that the NHS won't need as many staff as previously thought. There's likely to be a bigger focus on community-based careers, I would expect, than the current workforce plan. We've discussed this on the podcast before, but the RCGP has been very, very critical of the current workforce plan because it set out this vision of a huge expansion of the hospital doctor workforce with only a very small growth in the GP workforce, which clearly won't work for this government's vision of a community-focused NHS. In October last year, the government launched a 6-week consultation on what the new workforce plan should look like. And presumably, officials in the Department of Health are crunching through all of that information and working out what the final workforce plan will look like as we speak.
Will the workforce plan help address the jobs crisis in general practice? And what else will GPs want to see in this plan?
Yeah, I think it's really hard to say whether it will address the GP jobs crisis. In reality, possibly not, because fundamentally, as we've been talking about today, what needs to happen to sort out the jobs crisis is funding at a practice level. So I think it's more likely that changes to the GP contract would have a much bigger impact on the current jobs crisis than this very high-level workforce plan will. So things like what you were talking about earlier, what the BMA wants about pushing for a shift to practice-level reimbursement for GP roles rather than being part of the ARRS. And the RCGP has said something very similar about having ring-fenced funding specifically for GP jobs. So I think the contract is probably the key area where we could address this. On saying that, in terms of what GPs want to see in this new workforce plan, I think they will want to see some recognition of this jobs crisis and some sense that the government understands that it's a problem and it has some sort of plan to actually tackle it that's coherent in the wider workforce planning context. I think they'll also want to see some specific numbers attached to how many GPs we need over the next 10 years and how we're going to get them. So that means how are they going to expand GP training, if they're going to expand GP training, and what will that look like? Also, really important, what's going to happen to make sure we retain GPs once they've qualified. And that's about addressing the jobs crisis for new GPs, but also about how we keep GPs further along in their careers. The government and the NHS has done a pretty good job actually in recent years, hasn't it, of expanding GP training places, but it's been very poor on retention. So that definitely needs to be sorted out. And obviously, if they're going to expand GP training, how's that going to work? What are they going to do about the extra space and the extra trainers that are going to be needed to do that? That all needs to be planned. The other things I think that will be interesting is the focus on skill mix. What kind of focus on skill mix is in that new workforce plan? What does it have to say about that? Where will GPs fit into the multidisciplinary team going forward? Does the new workforce plan see their key role as playing a big job supervising all these other staff? The last workforce plan had a big emphasis on expanding the use of physician associates in primary care, and obviously that will all need to be looked at in this new plan. So it'll be really interesting to see what this government says physician associates' roles are, whether they have a role in primary care or not. And I think people will also be interested in whether or not it says anything about undergraduate medical training, how that should change if we're moving towards a community-focused NHS, what that means for medical students and how much time they need to spend out of the community potentially in general practice. And obviously the tech side of things is also really interesting. How much emphasis is there going to be on that and what that means for clinical staff in terms of training and the numbers of staff we need? As an aside, I think that new workforce plan will probably also have to explain how the NHS can attract, talented tech people with lots of experience of AI. We know Wes Streeting wants the NHS to become the most AI-enabled health system in the world. So, if we want to do that, if that's the ambition for the government, for the NHS, we need to have excellent technology people working in the NHS. And obviously that might be pretty problematic given the salaries that are available and whether or not they're commensurate with similar roles in other sectors. Probably not, I think most people would say. So while that's probably not on the list of what GPs necessarily want to see in the workforce plan, I personally think it'd be really interesting to see what it has to say about that and if there's anything in there that can kind of resolve that issue as well. Before we go, we've just got time for our good news story, which this week is about the GPs, practice nurses and a practice manager who were recognised in the New Year Honours List. GPs Dr Stephen Short from Nottinghamshire, Dr Neil Walden from Cornwall, Dr Graham Allen from Merseyside, Professor Nigel Hart from Belfast and retired GP Dr Christopher Cuff from Cornwall all received awards. In addition, primary care nurses Gillian Boast from Staffordshire and Jacqueline Whitnell from West Sussex, as well as practice manager Jan McCulloch from Ayr in Scotland, also received honours. There's more information about all of these people in the story on our website, which we'll put a link to in the notes for this episode. But a big congratulations to all of them. I tend to be the person who writes up this story at the start of every year, and it's such a positive way to start the year. It's always lovely to read about the impact all of these people have had on their patients and local communities. Well, that's it for this week. Thanks to Nick and thank you for listening. I'll be back next week, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access lots of other resources on our website at GPonline.com.